Hello again. This is Jessica Taddeo. My patient's comfortable laying down, so we're gonna leave him in that position, and I will go ahead and do a quick examination of his abdomen. Wash my hands first and greet my patient. As always, hello, sir. My name is Jessica Taddeo. I'm a nurse practitioner student. Hello. And I'm going to be doing an examination of your abdomen today. And I'm just going to reposition my camera here so we can see what's going on here. I'm going to move your shirt up and expose the abdomen. Yes. Okay. So, first part of the abdominal examination is inspection. I'm looking at the skin. I'm looking for any abnormal coloration. I'm looking at the shape, the contour, looking for any masses, pulsations, any peristaltic movements. I can see here, right over this way, is where his aorta, I can see the little pulsation of his aorta. I don't see any peristalsis. Sometimes it's hard to see, especially when you're a little fluffy. The next part of the abdominal examination is auscultation. You always want to listen first before you go touching because you can mess up the bowel sounds. You want to make sure that bowel sounds are there. So I'm going to listen in all 4 quadrants. We divide the abdomen into 4 quadrants: right lower, left upper, right upper. And then you can use that when you refer to where any tenderness or anything might be. So I would start in the right lower and go ahead and take a listen. Good. So he has positive bowel sounds in all 4 quadrants. Normally there should be like 5 to 30-ish bowel sounds per minute. Less than that would be hypoactive, and more than that would be hyperactive. There might be hypoactive in somebody who's really constipated or having some bowel ischemia or something like that, and then somebody who's having a lot of diarrhea might have some hyperactive bowel sounds, or even after a good meal, everything's kind of starting to digest, so you hear that. I'm also going to listen over the spleen and the liver and just auscultating for any splenic or hepatic friction rubs. Listen over the liver. Okay, and this is part of the, you can kind of do this in part of the cardiovascular, the peripheral vascular, or the abdominal. I'm going to listen over the aorta for any bruise. I figure since you have the abdomen out, this is a good time to do it. I'm going to listen over the renal. The iliac. And the femoral arteries. For any bruise or abnormal vascular sounds. The next part of the abdominal examination is percussion. So when we percuss the abdomen, I'm going to use the middle finger of my non-dominant hand and the middle finger of my dominant hand as the striker finger. And I am going to percuss. Normally you should hear tympanic sounds over the abdomen, except at the liver and if the spleen is or jaw dullness over the spleen. So we're going to palpate for the liver border. So I'm going to start at the umbilicus and kind of move over to the mid-clavicular area. And I'm just going to percuss, moving up. There, so you can kind of feel where it gets dull, or hear where it gets like of a dull sound versus the tympanic sound. And then I'm going to start over here in the mid-axillary area. I should kind of go from like resonant to dull sounds when you percuss going from the lungs to over the liver. So you can kind of measure the borders of the liver. If I had a tape measure, I could tape measure and measure that exactly. Say it's about 6 centimeters by estimation. I'm going to percuss over the left here. At the costal margin. And it should be. And if I go over the ribs, it's dull. But over the abdomen is kind of tympanic sound, so he doesn't have any splenic enlargement. The next part of the abdominal examination is palpation. So I'm going to do light palpation first, which is kind of one hand, kind of get them used to my fingers, warm them up a little bit in case they're cold. And I'm just going to kind of gently palpate. And while I'm doing this, just looking at his face, seeing if there's any grimacing or any guarding or ouch, when I lightly palpate. I think he's asleep, so this doesn't seem to be bothering him. And then I'm going to go ahead and do deep palpation. So I'm going to use both hands, and I'm going to press about 5 to 8 centimeters down into the abdomen. And I'm feeling for any masses or anything like that. And I don't feel any. He doesn't seem to grimace or have any abdominal pain, so that was good. If he did have abdominal pain, there's a couple things that you want to be really concerned about, and you can kind of focus your examination on that. So if he came into my clinic and said, I've been having some pain in my right lower abdomen, I might be concerned for appendicitis, and there's a couple different techniques that I can do to examine for appendicitis. The first one is McBurney's point tenderness. So when you look at McBurney's point, let me stand up. It's going to be like halfway between the umbilicus and then the hip bone. You just kind of draw like an imaginary line right about there. So I'm going to press down on McBurney's point. He doesn't say ouch, so it doesn't seem to have any McBurney's point tenderness. The other thing you can do, or the next thing that you can do for a check for appendicitis, is to check for rebound tenderness. Again, over McBurney's point here, you kind of just take one hand, kind of press deeply down, and then let go quickly. And if it hurts worse when you let go versus pushing, that is rebound tenderness. A positive rebound tenderness can be a sign of peritoneal inflammation or appendicitis. You can also do the same palpation technique on the left lower abdomen. So you kind of push in, release quickly, ask the patient which one hurt worse, when you pushed or when you let go. And if it's tender when you let go on the left lower side, that is called Robsing sign. And a positive rousing sign can also indicate peritoneal inflammation. The next is the psoas sign. So I'm going to let me move the camera so I can see here. I'm going to take his right leg here, and I'm just going to kind of go ahead and push your leg up towards your head. Push your knee, like this, your thigh muscle. Yeah, so kind of pushing, resist, do it again, so as you can see. Okay, so push this leg up like that. Push your knee up towards your face. There you go. All right, so that, if he's got pain in the right lower abdomen when moving that leg muscle up, that can also be an indication of peritoneal inflammation. And then the last one that we can do for appendicitis, and just move the camera here, would be to check the obturator sign. So I'm gonna kind of flex his leg here, and I'm gonna internally, externally rotate. It'd be easier if the back of the couch wasn't right there, but basically just a rotation of the hip. And if that elicits pain in the right lower abdomen, that can also be a sign of appendicitis. So all those would be concerning if I had a patient with, abdominal pain. We need to take a closer look. If I was concerned for gallbladder inflammation, for cholecystitis, I want to check in the right upper quadrant, so the gallbladder sits underneath the liver. And so what I want to have you do, sir, is you're going to go ahead and take a deep breath. And as he takes a deep breath, I kind of press down in that right lower abdomen. If the pain is so bad as I press, you can breathe, that in the right upper abdomen, if the pain is so bad that he kind of stops, like taking a deep breath, it was just like, when you press, that would be a positive Murphy sign and an indication for inflammation in the gallbladder. I've had my gallbladder out, and I don't think I would have let anybody touch me that deep on that side when it was hurting, but that would be the test. We can test for ascites. You can kind of hold the stomach together and kind of see if there's a fluid wave as you sort of percuss on each side. Sometimes you see like the fluid wave. I'm also going to have you sit up, sir, and check for CVA tenderness. Good job. Good morning. I move forward so I can see your back of the camera. That basically. Okay. So at the costal vertebral angle here, I'm going to just kind of percuss with my fist and my hand. Does that hurt? No. So there's no CVA tenderness. That would be present if there was pyelonephritis or pain in the kidney or anything like that. So that concludes the abdominal examination, and
I'll move on to the ears, eyes, and throat.
Sure. Okay. You don't want to do 99?
Whatever.
All right, let me pause the video and we'll start a new one for the next system. All right, thank you.